Hello, everybody. Thank you for joining today's NAMD webinar. We're going to just give it another minute or two to let folks join, and then we'll get started. Thanks. Hello, everybody. Thank you for joining the webinar. I'm just going to give it another 30 seconds or so, and then we'll get started. Thank you. Good afternoon and good morning to our colleagues in the western part of the country. I'm really delighted to have you here today for this National Association of Medicaid Directors launch webinar for our new report, Medicaid Forward Children's Health. I'm Lindsay Browning. I'm the Program Director for Medicaid Operations at NAMD, and really delighted to have you all joining us today for this event. For those who don't know, NAMD is the National Association of Medicaid Directors. We are the bipartisan nonprofit association that serves as the home for the 56 individuals who run the state and territorial Medicaid programs. Our mission as an association is to support the Medicaid directors and their teams in running cost-effective, efficient Medicaid programs that deliver high-quality care to over 77 million Americans that the Medicaid programs serve. Today's speakers, in addition to myself, feature a rock star panel of two other children's health experts. Gretchen Hammer is the Senior Strategic Advisor at NAMD and also the founder of the Public Leadership Consulting Group. Gretchen is formerly the Medicaid director in Colorado and has a long resume of experience working in children's health. And Gretchen was a co-author on the report that we'll be speaking about today. I'm also joined by Dr. Ryan Van Ramshorst. Ryan is a pediatrician by training and also the chief medical director for the Medicaid and CHIP program in Texas. So really excited to have his expertise and insight with us here today. And he was one of the executive working group members who helped inform this report. So really a good lineup of folks. So let me give us a little bit of context of why we're here today and why we're talking about this initiative called Medicaid Forward. We recognized as we were going through the pandemic over the last year that the trauma and the events that we were all seeing and experiencing were really going to fundamentally change the nation's health and well-being and change the healthcare system, quite frankly. Really, recognizing that the public health and economic ramifications of the past year, along with the racial and ethnic inequities that it really brought to light, are not going away anytime soon. That these are going to be lasting impacts that Medicaid's going to have a role in addressing. And we know that roughly 1 in 5 Americans rely on Medicaid or CHIP for healthcare, which means that Medicaid plays a key role in the future of the healthcare delivery system as we come out of the pandemic. So we launched this Medicaid Forward initiative really to look at some of the opportunities and strategies that Medicaid programs could use as we emerge into this new normal in American healthcare. And we focus this initiative on 3 areas where Medicaid plays a disproportionate role in the healthcare delivery system. And those 3 areas are mental health and substance abuse, access to care for kids, and then support for individuals in need of long-term care. So what we're talking about here today is the second of those 3, the Medicaid Forward initiative focused on access to health care for kids. And in case you missed it, our report around mental health and substance abuse came out earlier this year, and we'd encourage you all to take a look at that. So Medicaid Forward is a strategic framework of options really intended to support state Medicaid leaders and their teams and thinking about how they can contribute to the nation's recovery in these 3 areas. So we're really excited to share this work with you all today and dig into it in more detail. But before we do that, I want to turn it to Dr. Van Ramshorst and have him give us a little bit of a frontline perspective of why we did this work. You know, what children's health looks like, has looked like this past year as a pediatrician, and what that means for Medicaid leaders. So Dr. Van Ramshorst, I would love to just hear your reflections before we dig into the framework.
Thanks so much, Lindsay. It's really a pleasure to be with y'all today. So howdy, again, my name is Ryan Van Ramshorst, Dr. V for short. Again, the Chief Medical Director for Medicaid and CHIP Services at the Texas Health and Human Services Commission, which is the Medicaid agency for Texas. Our Medicaid program in Texas is the 3rd largest in the nation. We cover over 4.5 million Texans, 70% of which are children. Around 160,000 of those children have some type of medical complexity and qualify for SSI. And so, you know, children are always top of mind in our Medicaid program. I am a pediatrician by training, as Lindsay said, and I'm really fortunate to be able to continue to practice part-time. I just know that this has been really challenging for kids and adolescents and families. And I've seen that play out in my visits. And so I'll start by sharing a quick story with you. A few months ago, so before vaccination rates were as high as they are now, I was seeing a teenage boy that I'd been caring for about 5 years, and he was there for his checkup. The family was absolutely delighted to come see me in person, as I was to see him and his mother. And as I walked into the room, he jumped up and hugged me. And I was taken a little bit aback because we weren't really shaking hands or doing anything like that. And of course we were masked, and he hugged me pretty hard. And he said, you know, Dr. V, I'm so happy to see you. And then he said, COVID is hard. And I was really taken aback by that. You know, it's been hard for me. It's been hard for all of us, but hearing this young man verbalize that to me, and the way that he did it, the tone in his voice, the contact he made with my eyes was just really, really powerful. And when I did, you know, his psychosocial assessment, asked his mother to step out of the room, and was asking him, you know, how he was doing, you know, he expressed to me how difficult things have been by not being able to see his friends, difficulty seeing his mother, who has underlying medical issues, access care. And he verbalized, again, a young man whose brain is, as we all know, verbalized that he could see the stress in his mom and felt compelled to help as much as he could. And thankfully, he's doing well. He has some good coping mechanisms. He has some underlying mental health conditions that thankfully are stable. But I left clinic that day, you know, taking great pause. And I've heard these stories from so many of my provider colleagues, and I know we're all seeing this. And so I am also fortunate to have this wonderful role as essentially the chief medical officer of this Medicaid agency, and know that we have a tremendous opportunity to make a difference. And I'm really thankful that the way that we have structured this report starts with some short-term goals, some quick hits where we can really make an impact now or in the short term. And I really like how one of the top things is connecting. COVID has prevented us from having connections with loved ones, family members, colleagues, and providers on the front line have not been able to connect with their patients and families in the way that we have been before. And so I'm really pleased that one of the first things that this report calls out is we have to connect. The Medicaid agencies need to connect to the people that we serve. We need to connect with providers. We need to connect with managed care organizations, and we need to connect with other agencies and advocacy groups that are also laser focused on helping to support children and families. Another thing that I'd like to call out is that it was really a privilege to work on this with so many other thought leaders from other Medicaid agencies, from advocacy organizations, and I'd like to think most importantly, those providers on the front lines who are seeing these families day in and day out. One of the things we all commit to when we're going through our medical training is lifelong learning, and this was really a unique experience to bring everybody together. The other thing that we often say is if you know one Medicaid program, you know one Medicaid program. And so this was an opportunity for us to strategize, share best practices, and again, chart a pathway forward. I think we're all aware of the impact on well child visits. We're aware of the impact on routine childhood immunizations. We know that we need to get the COVID vaccine out there for our adolescents who are currently eligible and younger children when it comes online. But I think we're also very much aware of the long-term impacts of this pandemic on the health, well-being, and safety of the kids that we care for. And unfortunately, we don't know what a lot of that impact is going to be. And so I'm thankful that one of the other things we talked about is we need to be looking at this from a critical evidence-based standpoint to inform our policy decision-making down the road. And again, I've seen that play out in my practice, and thankfully I'm seeing a bit of a shift where when I'm seeing those teenagers, when I'm seeing those families, they're now talking about getting back to those things that they really deserve to be doing, connecting with their friends, going to a swim party, seeing grandparents. And so we're all seeing this light at the end of what has been an incredibly dark and scary and anxiety provoking tunnel. And again, this has just been such a unique opportunity to really chart a course forward for the single largest insurer of children in the United States and our territories. And so again, I really appreciate the opportunity to share some thoughts with you today. Look forward to the discussion from Lindsay and Gretchen, and look forward to Q&A as well. So thank you so much. I'll conclude my remarks there.
Thank you so much, Dr. Van Ramshorst. I think it's incredibly impactful to hear sort of what this has meant for the kids and the adolescents that you're serving. And we certainly see these impacts showing up in the national data. We know that the school closures have resulted in isolation and loss of learning and challenges with access to healthcare, with 77 million American students experiencing those partial or full school closures. And then in April, only 40% of kids, or more than 40% of kids were still not experiencing in-person learning. But I think the impacts expand beyond these impacts around isolation, but also to the economic ramifications that have really destabilized families. And we know that has an impact on kids' health as well. The reality of hunger increasing and food insufficiency increasing all have ripple effects on kids and their well-being. So I want to pause here and really hear from you all, our audience members, who I know are steeped in and living and breathing these children's health issues, and just hear a little bit about kind of what impacts are keeping you up at night the most as you think about children's health. So I pulled up a quick poll question and would love your all's feedback on this question. and I'll leave it open just for a couple more seconds here. All right, well, it looks like, let me share the results. It looks like you guys are most concerned about the social and emotional health of adolescents, which I think is not surprising and is something that certainly came up a lot in our work, and that Dr. Van Ramshorst was just talking about. I think the good news in all of this, and you see this on the slides here, the slide here, is that we know kids are incredibly resilient. And that we have an opportunity as leaders in the healthcare space and in Medicaid to support the resilience of kids. And that's what we're all about here. So Medicaid Forward Children's Health, we've alluded to this, but let me tell you a little bit about what it is. We know that Medicaid covers 2 in 5 American kids, Medicaid and CHIP, and that we have a role to play in that resilience, as I was just saying. So Medicaid Forward Children's Health provides a menu of options, a set of specific and actionable steps that Medicaid and CHIP leaders can take to put kids back on track, to support the resiliency of kids as we emerge from the pandemic. And we really divided the report into 2 sections, as Ryan was alluding to. That first section really looks at what are the short-term opportunities, the short-term levers Medicaid agencies can pull, between now and 6 months from now, to support children and their families as we emerge from the pandemic, as we get back to in-person learning, as we get back to daycare and normal activities. But the second section of the report recognizes that the healthcare system's been fundamentally disrupted, and we have an opportunity to use this disruption to think about longer term ways to transform children's healthcare delivery. And these things don't happen overnight. They don't even happen in 6 months, but they're strategies that folks may want to look at and consider at this moment in time to sort of drive some of that fundamental change. And then the report, of course, looks at some additional resources and materials that could help Medicaid and CHIP leaders that are interested in any of these strategies sort of pursue them further. So we're going to dig into those 2 sections. We'd love to take your questions as we go and as we get to the end as well. So please feel free to use that Q&A box and drop in your thoughts and your questions. And I need to also acknowledge the dedication and work of our executive working group who helped inform this report. This was not an NAMD internal effort. This was really driven and informed by a set of state Medicaid leaders who are experts in children's health and a number of national experts who helped with this effort and joined us as well. And then I also want to acknowledge and thank NAMD's foundation partners for supporting this work. In particular, I want to thank the State Health and Value Strategies Program and the Annie E. Casey Foundation, who were critical partners in this effort. So let me turn first to Gretchen to talk about some of the short-term response opportunities in the report and how Medicaid programs might be able to leverage those. So Gretchen?
Terrific. Thank you, Lindsay. And it is just such a pleasure to be with you all. As Lindsay mentioned, I have spent time supporting the association and working as a Medicaid director in the state of Colorado. But my heart and my soul has always been with moms and babies. That's what I was trained in my public health degree, and what I really have wanted to continue to focus on throughout my professional career. So the fact that children's health was one of the Medicaid forward topics was really a nice synergy between where I spend a lot of my professional time thinking and my support to the association. So what we try to do, as Ryan said, is to recognize that Medicaid programs are big and they can be a little unwieldy and at times not as responsive as we want them to be. But the time is now. The time is immediate to meet the needs of children and families who have been impacted by the pandemic. And so we wanted to start with a section of the report that outlined the short-term opportunities that we would really see the evidence would support and could be actions that Medicaid programs could take to really be responsive. So next slide, Lindsay. So first, as Ryan said, connection is the first step to reconnect with and understand the current realities of children, caregivers, and pediatric providers. The pandemic by design has disconnected us from the anchors that we know ground us to one another, and especially children, how they are grounded in their development by a variety of systems, many of which were disrupted. And so it really is important that state Medicaid agencies take a moment and think about how they can connect to the realities. There's obviously a lot of data that one can look at. You can look at claims data, evaluate customer service calls and appeals. What are people calling about? Where are parents frustrated that they're trying to get services for their kids and they can't navigate the system? We know that people are convening focus groups, either convened by yourselves or deploying staff. And then obviously we heard throughout the pandemic, one of the key strategies for responsiveness was to have established meetings with provider groups. So pediatric providers, Dr. Dumas from Louisiana shared with us that, it was through their monthly meetings with their pediatricians that they really came to understand the impact of the pandemic on both those practices as well as on the children. The other thing I will say here, and in a little bit, it's in response to the poll, is many people who work in Medicaid programs are parents. And we often have this odd separation between our personal life and our professional life. And I happen to be the mother of 2 teenage boys and spent this pandemic both professionally trying to navigate, but also personally trying to navigate my 2 children through school disruptions, sports disruptions, social disruptions, and other things. So at times, I think we need to give ourselves a little bit of permission to also maybe just sit around and talk about what do we know about the children in our lives, whether they're nieces or nephews, grandchildren, or the children that we parent on a daily basis, and connect with those in a real meaningful way. So that's the first step. Next, Lindsay. The other thing is to get back into that mindset that the state Medicaid agencies had at the beginning of the pandemic, right? I know the state of Washington used a phrase called a sprint team. Like, oh my gosh, we have to transition telehealth for our home and community-based services. Get 10 people in a room, let's figure that out. How would we do that? So these sprint teams really help us act quickly on solutions. I think Cindy Bean is famous in saying on either a podcast or something like, we used to think Medicaid couldn't move quickly, but boy, have we proved ourselves wrong in this pandemic with the amount of policy we've been able to change. So really trying to make sure that, one, the new policies you have put in place are being supportive of children and families, and then seeing if there's anything that needs to be done additionally to support children and families. And then, as Ryan said, we know that Medicaid programs have played a critical role in advocating for the needs of Medicaid enrollees in vaccine planning for adults who may be homebound or older adults who may be in nursing facilities. And then certainly as we're trying to look at equitable distribution of vaccines, we believe Medicaid programs have a role to play. They will also have a critical role to play when we get to the children under the age of 12 to be able to have the vaccine. We also know that the public health emergency has created some unique eligibility challenges, right? It has maintained coverage over the course of a very long and critical period of time. But when we get to the end of the public health emergency, there will be quite a bit of shifting going on in the eligibility systems as people who were maintaining coverage but may not be still eligible for the program are evaluated for their current eligibility. That could be a real disruption for kids and parents. And so having the focus of children and parents in that planning is really important. And then, as Ryan said, it's not been easy on pediatric providers either. This has been a challenging time. They love seeing children. They themselves, their business model has been put into question, and they themselves have been afraid as frontline essential workers of bringing home COVID to their families. And so there's a real need to continue to find ways to support pediatric providers. Next, Lindsay. And then specifically, we did talk in the executive working group about the unique needs of adolescents, both from their general health, things that need to be attended to as young people go through their adolescent period, but also in particular on their mental health. And this is a place where it is incredibly important for Medicaid programs to see the system of support that is trying to address adolescent mental health. I mean, one of the things that we evaluated or talked a lot about in the executive working group is how connected children's health systems are, or children are to a variety of systems, right? They're connected to their school system, they're connected to potentially the child welfare system if they happen to be involved in the child welfare system. They're connected to their community structures, their sports, their theater, whatever else they might be. And Medicaid needs to be thoughtful about how are we contributing to a larger effort. So example, in Colorado, a piece of legislation passed to create access to some adolescent mental health visits for all children, all adolescents in the state of Colorado. A very important piece of legislation by a legislative champion for adolescent mental health. How that connects to Medicaid, the Medicaid benefit, as well as those children's private health insurance benefit, is really important to get aligned. So one of our first ideas in the executive working group was really making sure you're actively participating in all of the other activities that are being dedicated, right? Schools are ramping up for a return to school in the fall, hopefully with a better understanding that the social and emotional development disruption has been significant. We've also heard anecdotally, but I think also looking at the evidence, that telehealth continues to be a really good way to engage with adolescents, right? If you live with one or you know them, they're often very close to their telephone. And so the opportunity for them to connect with a provider, hopefully they still get to hug their provider like Dr. Van Ramshorst's patient did, but if not, engaging over telehealth is really quite powerful for that age group. Also, including adolescents in your quality improvement initiatives. I spend a lot of time through my work looking at the clinical quality strategies of Medicaid programs, trying to help make sure we're attending to the clinical quality. And there aren't that many often focused on adolescents because it's a group that's often not pretty disconnected from care. So is there a chance to improve through the normal incentives when we're trying to improve access to services or improve the quality of services to include adolescents in that? And then lastly, we talked a lot about the limited workforce that is available to provide supports to teens. And one way you look at that is in a defeated way, like, oh, we just don't have enough people. The other way we look at that is anyone who's talking to a teen needs to be ready to have a conversation and to support them with their behavioral health and health needs, right? Or connect them to the right person. So can we broaden our understanding of how to integrate physical, mental health, and addiction treatment and make sure that we're doing that in a holistic way? Because we're unlikely in the next 6 months to be able to find new adolescent health providers that are going to be standing there ready to take on a huge caseload. So that means we have to leverage who we have and who we can deploy. Next slide, Lindsay. And I think that was the breadth of it. The one other group we did talk about, and I'll just give a shout out quickly, is children with special healthcare needs. In the report, there's a call out box that focuses on their needs. And we talked about things like prioritizing them for their parents for vaccination, as well as themselves for vaccination, as well as thinking about the things we did to ease the experience for children with special healthcare needs and their families. Which of those should we continue to maintain as we go back to normal operations? We did some things like changing prescription timelines and things that really families have said, wow, if we could do it like this all the time, that would really be great for us. And so I think there's an opportunity when you read the report to also find opportunities to support children with special healthcare needs. Lindsay, I'll turn it back over to you.
Great. Well, I want to lead us into the last section here, which is looking at how, as I said at the outset, we can use this moment of disruption, not only to stabilize children and families, but to think a little bit differently about how we deliver healthcare to children and to their caregivers. And so we did this separate section to recognize that some of these strategies can take years to implement, but that we may be in a window of opportunity for folks to be able to begin to advance some of these more longer-term transformative opportunities. So we really looked at this section in three ways. We looked at the opportunities that Medicaid programs have to support the healthy development of children from all life stages, from birth through that transition into adulthood. We also looked at the opportunities that Medicaid and CHIP programs can use to stabilize and support the health of families. And then finally, we look at some of the ways that Medicaid can support system alignment around kids. So I'm going to go into each of these in a little bit more detail, but that's really the framework that we brought to this transformation section. So we focus first on the healthy development of the nation's children. And the reason why we started here was a recognition that Medicaid has a unique role in supporting kids at all life stages of development, but particularly for young children age 0 to 3, where we know that those events and what happens in that period of time can really set a child on their life course trajectory, on a trajectory of health and well-being. In particular, recognizing that Medicaid covers about half of all births. So we have a disproportionate role in giving kids that foundation for lifelong health, particularly in the first couple of years of life. So we looked at some options and strategies for how Medicaid programs might approach this. And the first is looking at ways to potentially streamline those eligibility pathways for children and make sure that there aren't gaps in coverage that result in disruption and not accessing services at key points of that developmental curve. So things like, newborn enrollment strategies, presumptive eligibility strategies. We also look in the report at how you could increase access to services that support strong development. And these are things like the Bright Futures guidelines, which are evidence-based standards for screening and the social and emotional supports that kids need. We also look at integrated care here, integrated physical health, mental health, and addiction treatment. And I think this is one where, when we're talking about adolescents, this is particularly critical, right? That we can't miss the opportunities to intervene and provide these services when an individual is a teen and maybe dealing with a mental health challenge for the first time. And the opportunities here are things like supporting pediatric primary care, removing requirements that you have to have a behavioral health diagnosis before you can get some behavioral health treatment. And focusing on that, again, that capacity to provide integrated care. And then the fourth set of options we focus on is how do we support that academic and school success in thinking about things like incentivizing plans to make sure kids get the well child services they need, the screenings they need before they go into school, so that when they enter school for the first day, they're ready to learn. They can see the chalkboard and they have the supports they need. The second aspect that we look at is how do we promote healthy and stable families, and what are the levers that the Medicaid has in that space? And again, the rationale for focusing here is that we know when a caregiver is healthy and stable, that a child is more likely to be healthy and stable as well. So what happens to the family unit really matters when we're thinking about health outcomes for kids. So some of the strategies that we looked at here is, how might we support a pregnant mom after she's had the child, in that postpartum period. So the option to extend coverage 12 months postpartum that we know a lot of states are looking at right now is one of those potential strategies. We also look at some opportunities to increase access to healthcare services for parents. And some of these strategies aren't dependent on sort of what threshold, how broad your eligibility is for childless adults or parents in Medicaid. But there are opportunities to do things like depression screening for moms as part of the child's Medicaid benefit, or to do dyadic mental health treatment for a parent and a child together. And then, of course, another opportunity there is addiction treatment that allows the mom to stay with their child and really bond as a dyad while receiving that treatment. So sort of a range of opportunities there to think about supporting the parents. And then, of course, those other social supports, services and supports that we know can provide stability, right? Medicaid can't pay for housing or some of these other things, but Medicaid can play a key role in connecting pregnant women, connecting new moms or new caregivers to the social services and supports that exist to help stabilize. So connecting to WIC or SNAP or housing supports that may exist, and doing that sooner rather than later, right? If you can stabilize and provide those supports during the prenatal period, the perinatal period, it's going to set caregivers and their children up on that path for success. And then finally, we look at systems as the third place for advancing long-term transformation. And I think in a lot of ways, this is the trickiest one because Medicaid is one of many, many programs and systems that serve children. And this work of cross-agency collaboration can be really difficult, particularly when there are changes in leadership. But I think the good news here is that there are some tangible and concrete ways that Medicaid can step into this space and play a leadership role in bringing systems together around kids. The first set of opportunities we look at is, how can you share information and learning between Medicaid and child serving programs? Can you periodically hold meetings with them? Can you do a lunch and learn where they come and speak to your staff about the key issues they're working on, the key priorities, and vice versa? But really that connection and information sharing can be a really light touch way of starting to build that knowledge and connection. Also, there are opportunities, you can identify opportunities to share resources. And I think this requires some trust and relationship building to get to that point. But you can do this through, sharing data. All these programs are serving the same families and kids, right? So the information, the data we can share can help us all make better informed decisions. Sharing staff, lending our staff to one another to build that expertise. And then, of course, braiding and blending of funds is another way of sharing resources as well. Strengthening governance of those collaborative activities. This can create structures that stay in place despite changes in leadership and create processes that support collaboration. So things like an interagency liaison that's designated to work with the MCH program or with WIC and SNAP, the nutrition support programs, or maybe an interagency work group that brings all of these key folks together to talk about shared priorities and challenges. And then finally, the fourth set of options that we looked at in this bucket is, how can we equip providers to jointly deliver services and coordinate with the community-based organizations? Particularly, we know that pediatricians don't have time to, make all these referrals and connect folks to WIC and SNAP and TANF, et cetera. But if we can think about bringing in other members of the care team, really thinking about the care team to do some of that connecting, that's an opportunity for Medicaid. So bringing in peer supports, leveraging doulas, leveraging developmental specialists to really broaden out the care team and again, make those connections. Providing TA to providers around this coordination of services and making connection to social services and supports. And then the big kahuna of alternative payment models as a way to pay for and support new innovative care delivery models that can do some of this work as well. So obviously it's a whole range of opportunities and strategies that we outlined in here. And before I move on, I wanted to pause here again because I know we have a lot of folks from different backgrounds, from different seats participating in this webinar. And I wanted to ask a second poll question as you particularly reflect on this idea of systems alignment and ask you all sort of where you see the biggest opportunity for Medicaid to strengthen its partnership with some of these other child serving programs. So I pulled up that poll and would encourage you all to take a quick moment to fill that out. And I'll keep it open just for a couple more seconds. All right, not surprisingly, I think that the biggest one on here, the biggest opportunity folks identified is with schools and the Department of Education. And this is consistent with a conversation we had last week with a group of states around this as well, where we talked about opportunities for Medicaid to strengthen its partnership with schools and think about increasing access in those school-based settings. So perhaps we can get into some of that discussion as we transition to Q&A, but I just wanted to leave you all with a couple of next steps here. And the first one is that we would love our state Medicaid agency colleagues to share your feedback with us. This report is a first step. It's not the end of the line. And we really intend to support programming for our members to help you think about and leverage some of the strategies described in the report. So send us your feedback. If there's a particular piece or strategy that resonates with you, we would love to hear that. And then I would also encourage everybody on the webinar to really stay connected with NAMD. And the best way to do that is to sign up for our newsletters. And our state colleagues can sign up for our state-only newsletter, and then we have a public newsletter as well. So you can do that at our website, medicaiddirectors.org. So with that, let's transition into some Q&A. And I see we have some questions that have come in from folks. The first one that came in is around how folks are thinking about, emerging from the public health emergency and what strategies, what policy changes to keep in place post PHE. So I'm happy to start, and then I would love Gretchen and Dr. Van Ramshorst to jump in as well. My sense is that folks have undertaken a pretty thoughtful and deliberate process of how to look at the flexibilities they put in place. And I get the sense that a lot of states are, having stakeholder meetings, talking to their legislature, particularly around a lot of the telehealth flexibilities, and figuring out, what that looks like as we move forward. But I think particularly with telehealth, I think it's fair to say it's here to stay. It's just a matter of what are the right guardrails to put around it, and where is it most effective clinically. So Gretchen, Dr. Van Ramshorst, what would you like to add on that question?
Go ahead, Gretchen.
No, Ryan, I was going to defer to you as the both clinician and Medicaid person.
All right. Well, I'll call out a couple things. From a programmatic standpoint, I think one of the things we have really tried to do looking forward in Texas is reflect on the Medicaid agency's response to previous disasters, which in Texas have largely been hurricanes, and how can we make sure that if and when the next pandemic arises, we know exactly the type of things that are helpful and meaningful, and here is how we do them. Is it state approval? Is it federal approval? What type of a waiver do we need to request? So the next time around, we are in a much better position to hit the ground running. And so I think that's been something we've really been focusing on, especially now as things are getting to a better place and we know that we're closer to the end of the public health emergency than we were earlier on in the pandemic. I won't touch upon telehealth because I know Lindsay touched upon that. I think another thing to really call out, and this was on Lindsay's last or second to the last slide, is that cross-agency collaboration. One of the other hats I got to wear was I was proud to serve on Texas's expert vaccine allocation panel, which was a group of 17 thought leaders to include elected officials, public health experts, epidemiologists, and our Department of State Health Services, which was our lead state agency for pandemic response, recognized that Medicaid needed a seat at the table. And I was fortunate to play that role and provide feedback and engage in dialogue. And we had a good relationship with our public health agency before the pandemic, but I think it's so much stronger now. And we certainly hope that moving forward, there's going to be much more alignment between public health and Medicaid, especially when it comes to things like children's health. A couple other things to call out. It's not directly a public health emergency flexibility, but figuring out ways to support primary care providers in addressing behavioral health issues. This has obviously been on the radar for quite some time, but I think this is going to be a bigger issue moving forward for a variety of reasons. And so how can we support those pediatricians and family docs and nurse practitioners who might not have received training on how do you address a child with suicidal ideation in your clinic when they went through residency training? And so how can we connect them with something like a Project Echo model? In Texas, we have something called the Child Psychiatry Access Network, where a primary care doc can call and speak to a child psychiatrist. I help this child in front of me right now. And then the last thing I'll call out, vaccines are certainly top of mind, routine immunizations and COVID vaccine. And I know that many Medicaid agencies have been thinking of out of the box solutions to get children vaccinated, and really thinking about how do we make it easier for families so they don't have to take two different bus routes to get to the clinic to get that vaccine. What is the role of schools? What is the role of mobile clinics? And what is the role of pharmacists? This has been an area of much vibrant discussion before the pandemic, but I think Medicaid agencies are uniquely suited to work with those provider groups and articulate here is what the role can be. And again, not necessarily thinking about that from a provider standpoint, but how can we make it easier for families to get those immunizations to include the COVID vaccine? So thanks.
Great. We got a question related to housing, going back to, I think, the comment I made about Medicaid not paying for housing, but we do know there's some innovative programs going on in this space. So Gretchen, do you want to just share a little bit and respond to the question we got there?
Sure. So very just briefly, I wanted to bridge between the two Medicaid Forward reports that have been released by NAMD. We focused on individuals experiencing homelessness as a special population in the Behavioral Health Medicaid Forward report. And during that executive working group discussion, the area of homeless families came up as a unique population that is really difficult to serve, that many Medicaid agencies have found success, and managed care companies, in helping connect individuals, either men or women, to housing supports, but that family programming was a real gap in services. And so just because we're talking about children and it was a bridge to the other one, I just wanted to take a minute to make that connection. And for everyone on the phone to think about, are we accommodating the needs of homeless families and children experiencing homelessness when we're thinking about those other connections that Medicaid programs are making?
Great, thanks, Gretchen. We got another comment in here, I think around the point one of us made earlier around kind of connecting and hearing from the folks we serve. And the comment was around family to family health information centers and family voices really being a resource for states to be able to go to engage with families and have families help inform the policy making process. So that's definitely something we've heard, and we've engaged with family voices on a couple of these Medicaid Forward executive working groups. So good to hear that echoed. And then a question came in around patient-centered medical homes, and Gretchen and Dr. Van Ramshorst, I think you guys will both have some good insights on this. So the comment is that patient-centered medical homes and integrated behavioral health care are both proven, and we've got some good evidence to show that they work. But practices are pretty hesitant to move in that direction. It's hard to do that given the costs involved in the practice transformation. How do you guys see opportunities for Medicaid to work with providers, to work with pediatricians in particular on that practice transformation work?
So I'll take a stab at that. Lindsay, you mentioned alternative payment models earlier, and I think that's really the space where progress can be made here. In Texas, we have held our managed care organizations to have 50% of their payments in some type of an alternative payment model. And we know that some of those organizations are doing APMs in this integrated behavioral health space, where they are helping providers afford this model, which, as we pointed out, costs money. You might need a physical space for the therapist to be in. There's additional expenses to having a shared medical record. And I just wanted to point out there is a difference between co-location and integrated services, but I really think operating in alternative payment models rather than the older just fee for service model is going to give MCOs and providers that flexibility to innovate, and certainly in the space of integrated behavioral health. And I've seen the value of that in my practice. Having the therapist down the hall from me, I can essentially call a consult. She can go in and help evaluate my patients. We have a shared medical record. She can see my notes. I can see her notes. And it's just another resource, a tool in that provider's toolbox, because they might not have more than 15 or 20 minutes to spend with that patient.
Super helpful.
Yeah, I would just say, in addition to those big alternative payment models, we do know of some states, the state of Alabama just really doubled down, as well as the state of Rhode Island, on primary care transformation efforts, including specific call out for pediatric primary care. The PCMH Kids program in Rhode Island is pretty robust. And I think they're looking at how do you provide some additional resources for the additional staff, those additional care teams, as well as that infrastructure that Ryan was talking about. So I think those are some really good models.
We got another good question here about the increase in child welfare cases. And I'm glad this came up because we spent some time discussing this as an executive working group too. But the question is that, they're seeing an increase in cases across the nation, and including families who haven't had previous interaction with the child welfare system. What are the ways we can leverage Medicaid in, sort of catching these cases before they become critical incidents? And particularly recognizing that the telehealth is here to stay and could be a component of that. So do one of you all want to jump in on that question?
One thing that we've really started to focus on more than we had previously is connecting with our child welfare agency, the Texas Department of Family and Protective Services, and of course, strengthening our relationship with our child protective services, but also the prevention and early intervention area of that agency. More upstream. How can we work with the prevention and early intervention area to connect families with those, whether it's through a nurse home visitation program, parent education and training, but really trying to think upstream. And I think also making, and providers are aware of this, but making sure, again, they have the tools to intervene early when they can sense additional stress in the family. And of course, taking care of that child, but how do you connect those parents, those caregivers to services that they might need that would prevent something more challenging, like an interaction with the child welfare system, from happening earlier. All of that is much easier said than done, but I think the first step is just being mindful and aware that this is an issue that has become more serious related to the pandemic.
Yeah, and I would only add to that, I really appreciate the question. And one of the things we talked about, and we were lucky to have Frank Alexander from NAEKC as one of our executive working group members, and he was the director of one of the county child welfare services places in Colorado. And he really reminded us of the impact of child welfare on very young children. The number of infants that are removed from their home, their parents, at the point of birth or in the first year is actually shockingly high. I don't want to quote a statistic because I'll get it wrong. But I do think that some conversations around child welfare can be for school-aged kids and above, because they're getting bounced around through schools and others. And I would say, even when I was Medicaid director, perhaps not enough attention on the interaction with child welfare for very young children, that we know are, from the child welfare statistics, are in out-of-home placement quite regularly at rates that are worth some dedicated attention.
And just to piggyback on that, I know we mentioned earlier during the slide deck, moms with babies where mom has a history of a substance use disorder, and trying to find ways to allow and support that mom in staying connected with their child. And what do we need to do to support that mom in terms of facilitating her ongoing treatment for substance use disorder so she can stay with her baby, and preserving that family unit.
Great. We got another question in as well, and this one I think is really timely too, around children's mental health, children who are in crisis with mental health conditions. And I think we saw recently, Colorado Children's Hospital, I believe, was declared an emergency, state of emergency, because of the number of suicide attempts that they have been seeing. And this is certainly a pressing concern across the country. But the question is, what do we do if there's not enough capacity to care for those kids that are presenting in EDs in mental health crisis?
I think this is really about, again, thinking upstream and thinking about the continuum of care and making sure that those services are readily available before a child would be in a crisis situation. I think telehealth is going to help us do that. But there certainly is a subset of kids that have severe mental illness, that have a history of multiple psychiatric inpatient admissions, that frequently are going to the ER. And that's a very challenging space. In my clinical experience, most of the time there's some other underlying psychosocial stressor in that family, like food insecurity, housing insecurity, a parental mental health issue. And so thinking about ways to address that. But I know this is an issue that all states, including Texas, are challenged with right now. And again, it's Medicaid cannot go at this alone. And so how do we connect with other agencies and community-based organizations to wrap in families?
Yeah, I think that's right, Ryan. I also think, though, it is a leadership opportunity, right? It is the chance for a leader in a Medicaid program to say, let's put together one of these sprint teams. I want all my best minds around a table to try and help solve this, and maybe find some creative solutions that through our normal channels of operation wouldn't be there. And I agree with you. That table should be as broad as it can be. Hopefully, like your vaccine task force in Texas, the best minds in the state, including the Medicaid program, really coming together to solve this holistically. But it is a place where, using our typical policy development processes and stakeholder engagement processes and administrative procedures, we may not be acting quick enough. We may need to move a little bit more quickly to be responsive.
And I think I would just add that, there's clearly a push in funding for Medicaid and behavioral health agencies to expand their crisis system. And I think I've heard Medicaid directors talk about youth being an explicit focus in that crisis continuum. And we know that when there are good crisis services in place, you can mitigate the need for going to the ED in a good proportion of those cases, right? Of providing some of the stabilization with a crisis unit, connecting folks to other sources of treatment. So I think that piece of work is ongoing. Obviously, we're not there yet completely, but I think can help mitigate some of these challenges. Great. Well, I think that's the questions that we've gotten in. We got a question around NAMD partnering. We're always happy to have conversations, so please feel free to reach out. I'm happy to sit down and talk about how we can continue to partner with our provider groups, other groups in the Medicaid space. Really appreciate Gretchen and Ryan, you both, for taking the time to share with everybody today. And for those who've joined us, we'll send around the slide deck after we hop off here, as well as the link to the recording for those who weren't able to join, or if you have colleagues you want to share it with. So thank you all very much. Look forward to continuing to work with you and collaborate around these children's health issues. Thanks so much.